Well, thank you. We're very fortunate to have Sarah Burr at the helm with our infection control program, and brings a vast amount of experience from Maryland and has just been incredibly valuable. Hope you found that case review instructive. So many take-home points there, and we're certainly using it from a quality management standpoint to teach our infection control officers around the country. And you know, in retrospect, it always looks like, well, why didn't you think TB? But then if you think, you know what, the last 150 patients that I saw with cough didn't have TB. And we're seeing these TB cases occurring in very low incidence states where I said many of our practitioners have never seen a case of TB in that prison during a 20-year career. So a lot of education that we can all do jointly, I think, that foreign-born populations in particular are at risk no matter where they're located. So what's new in TB control? I think we've talked a little bit about the interferon gamma release assays. In our current guidelines, we do not recommend their use, but we are reconsidering that, particularly for our foreign-born population. It is a blood test. You're stimulating mononuclear cells, cell-mediated immunity with mycobacterium antigens to cause release of interferon gamma. So it is a blood test, different from a skin test, and it has some advantages over the TST. You know, with TST, you've got to do lots of competency assessment and interpretation of that induration versus redness. We've all been there. You need the return visit for the TST read. You have the booster phenomenon with the tuberculin skin test. And in our foreign-born population, you have that confounder of the BCG vaccination, which can give you a false positive TST, which you don't get with the IGRA. So what are the hurdles with the IGRA? Well, one of the main hurdles is logistical, because you can't take 30 samples and leave them at your jail for a month and then send them to the lab. They have to go really that same day. And you have to have a lab locally, usually, that can do that testing. And it's costly. So those are the challenges with IGRA, but there are advantages, and we are looking at how to apply it to our correctional setting in the Federal Bureau of Prisons. I think it's always instructive when you look at guidelines to see how to apply in public health. There may be controversy. For IGRAs, you have the CDC guidelines, you have the guidelines from Canada, and you have the guidelines from the United Kingdom, and you have the guidelines from Europe, and they're all different. So obviously public health experts are challenged with coming up with a concise application, which probably means you have to look at your setting and determine whether or not IGRA should be used and where in a strategic manner, and that's what we're doing in the Bureau of Prisons. There are new diagnostics that are very exciting. On the molecular level, nucleic acid amplification tests are being used more and more and available to jails and prisons. They're most helpful when you have a smear-positive patient. And of course, do you isolate? Yes, but how long? Do you stop inmate movement? Do you embark on a contact investigation, which you can see can be quite complicated? So getting a test back, a result from the lab to say, yeah, that positive smear is most likely M. tuberculosis, can be very helpful and has a very good test rate on a positive smear that, yes, this is M. tuberculosis on your nucleic acid amplification test. If the test comes back negative, but you have a positive smear, then maybe you may want to still isolate that inmate, but not embark on the contact investigation or stop inmate movement until you get the culture results. A lot of exciting things happen with rapid tests for drug resistance. I had the fortune of visiting Moscow recently, and there in some of their prisons, when an inmate shows up with hemoptysis, they're dealing with rates of 5, 10, 15, 20% multi-drug resistance. So if you have 10 inmates coming in with hemoptysis, how do you isolate those 10 inmates? And if your facilities are limited, they are in Russia using the evaluation, molecular evaluation of sputum to determine rifamycin resistance. So I think this has a lot of potential, particularly where you have populations that are at high risk for resistance, to make sure that you're getting as rapid a diagnosis as you can so that you can limit exposure within the high-risk congregate setting. And probably the most historic thing that's happened, at least in my career in TB, is the potential for a much abbreviated treatment course for latent TB infection. We're using our 9 months of biweekly isoniazid in the Bureau of Prisons, and we can do it directly observed within the correctional setting, but that's a long time to give medication. You're probably aware of the short term of pyrazinamide rifampin regimen that we tried in some correctional settings in the United States, not in the Bureau of Prisons, but that is no longer being prescribed because of the concerns of hepatotoxicity. But I hope you are aware of the New England Journal of Medicine article by Dr. Sterling and the MMWR from December that highlighted the abbreviated course of rifapentine and isoniazid, which you can give with just 12 patient visits, weekly visits. Rifapentine is a rifamycin that has more potency than rifampin against MTB and has a very long half-life, so you can get away with the weekly treatment. Corrections is an ideal setting for this because we know where our patients are. We can bring those inmates or detainees in for their medications and make sure that they get all 12 doses of the INH and rifampin. In the New England Journal of Medicine article, they compared thousands of inmates in either getting the self-administered daily isoniazid with the weekly INH rifapentine, 900 milligrams for both the rifapentine and the INH for a 50 kilogram adult. And what they showed is that the abbreviated course of the INH and the rifapentine was as safe as the daily administered INH, and that the completion rates, not surprisingly, were much higher for the abbreviated course. There was less hepatotoxicity with the INH and rifapentine. There were more concerns about the hypersensitivity reaction and some inmates with hypotension. So as I've already said, this is really an extraordinary opportunity for corrections to provide LTBI treatment to inmates who often have eluded traditional public health networks. Those with HIV infection who are not on antiretroviral therapy. You can't give this regimen if you're on antiretroviral therapy, but one of the things we're looking at in the Bureau of Prisons, particularly for inmates with high CD4 counts, is to give them their treatment for their LTBI first and then starting your antiretroviral therapy. We are concerned about potential adverse side effects that have not been detected because this hasn't been a regimen used in thousands and thousands of inmates, although the studies have been fairly large. But sometimes we see side effects emerge with new regimens when we start treating larger populations. We are going to be integrating this into our updated TB guidelines that we will provide on the internet. Part of the caveat will be very close monitoring of side effects for the INH rifapentine regimen. We're going to coordinate that with the Centers for Disease Control. So in conclusion, hopefully this has been helpful for our audience here locally in Baltimore as well as nationally across the country. I hope we've made the point that correctional facilities should be a target for public health. We have high-risk populations. We have foreign-born inmates across the United States in jails and prisons, and we do know that outbreaks can occur in these congregate settings and eventually affect the community at large where these correctional facilities are located. But by and large, this isn't the big issue for corrections because fortunately we do overall, I think, an excellent job in controlling TB and not having outbreaks, but we're still a very, very critical venue in jails for identifying those individuals who are just lost in the public health infrastructure. They're homeless, they have AIDS, and they're using drugs, their addiction, and they're not going to substance abuse treatment, and they're showing up in our jails where we can identify these individuals and get them on TB treatment. And then, as I mentioned, for prisons, a really critical opportunity, particularly with INH and rifapentine, if it bears out, to give these short courses for LTBI treatment to high-risk populations. And lastly, as hopefully TB will continue to decline in this country and the case rates will continue to abate, we need to keep in mind that many of our healthcare providers have very limited experience in diagnosis and treatment of TB, which makes our role in public health that much more important. Thank you.